Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 380 of our pharmacotherapy series, which majors in pain and its management. The first question applies to patient JPK in part 379 of this pain series. JPK has been taking 2 different muscle relaxants for his back pain. He reports that neither of these is very helpful, and he usually does not have muscle spasms, but does have trigger points on physical examination. So my question to you is, what would you recommend with regard to continuing these drugs? Would a trial of a different muscle relaxant be appropriate? Muscle relaxants are commonly used to treat chronic musculoskeletal pain. They are recommended for short-term use for acute low back pain. All are fairly equal. Chu and colleagues performed a systematic review of trials to compare efficacy and safety of skeletal muscle relaxants. Although the evidence was considered to be of fair quality, they concluded that for the treatment of musculoskeletal pain, tizanidine, orphanadrine, carisoprodol, and cyclobenzaprine were more effective than placebo. There were not sufficient data of good quality to determine whether metaxalone, metocarbamol, chlorzoxazone, baclofen, or dantrolene was better than placebo for this indication. At this time, guidelines do not recommend chronic use of muscle relaxants for musculoskeletal pain. There is a small study that shows improvement in myofascial pain with tizanidine, but there are no data supporting continued use of carisoprodol or cyclobenzaprine. These agents belong to a chemically diverse family, but all work in the CNS, either in the brain or in the spinal cord. They are categorized as either antispasmodics or antispasticity agents. The antispasmodics are either benzodiazepines, e.g., diazepam, or non-benzodiazepines, e.g., cyclobenzaprine, and are used for muscular pain and spasms associated with peripheral musculoskeletal conditions. The antispasticity agents reduce spasticity associated with upper motor neuron disorders such as multiple sclerosis, e.g., tizanidine, or baclofen. Because JPK has not experienced any improvement in his pain with previous trials of muscle relaxants, switching to another is not likely to yield any improvement in his symptoms, though tizanidine has shown some promise. JPK returns after 3 months with a small improvement in his back pain. He is sleeping a bit better, that is for 6 hours per night. He is attending physical therapy sessions, although infrequently. He has been taking citalopram 20 mg by mouth daily for his depression and feels that this is somewhat helpful for his mood. He has been taking naproxen 500 mg by mouth 3 times a day and gabapentin 300 mg by mouth 3 times a day for his pain. Neither of these has provided adequate relief. Another provider gave him a prescription for oxycodone 5 mg co-formulated with acetaminophen 325 mg 1 to 2 tablets every 6 hours as needed. JPK has been taking 2 tablets every 6 hours on a regular schedule. This helps his pain, corresponding to a 30% improvement, and he notes that the addition of the opioid has allowed him to start working part-time again as a handyman. However, the relief only lasts 3 to 4 hours, and then he is in pain for another 2 to 3 hours before he can take another dose. He also reports a lot of nausea with this regimen. He has heard about pain patches and wonders whether these might be an option for him. JPK is getting about 30% improvement with oxycodone co-formulated with acetaminophen, which is a good response for any analgesic, but the duration of relief is short, and he is having nausea after each dose. He has asked about using a pain patch. So my question to you is, what therapy might you suggest to optimize JPK's analgesia? Is a pain patch a good choice? Although opioids are not recommended for chronic low back pain, JPK has noted an improvement in pain and function. It would be reasonable to consider continuing his analgesic combination. There are several analgesic options available for patients who are unable to tolerate or ingest solid oral dosage forms, that is, tablets and capsules. It is common for patients with feeding tubes and patients who have maxillofacial surgery to use alternative dosage forms such as oral liquids, topicals, or transdermal products. JPK has asked about a pain patch. It is likely that he is referring to either a fentanyl transdermal system or a buprenorphine patch. These agents offer extended delivery options, but are often not cost-effective. Therefore, a pain patch may not be the best choice for JPK, because he is able to take oral medications. It would be most reasonable to rotate to an oral opioid that offers a longer duration of action. When considering product rotation for JPK, it is important to consider drug formulation and availability, route of administration, drug interactions, adverse effects, and cost. The oxycodone co-formulated with acetaminophen product that he is currently using is not providing an adequate duration of analgesia. He may need to use an extended release or long-acting opioid to achieve sustained analgesia. There are many extended release or long-acting opioid formulations available, including morphine, tablets, or capsules, oxycodone, tablets, hydromorphone, capsules, methadone, tablets, oxymorphone, tablets, hydrocodone, capsules, or tablets, buprenorphine, patch, or buccal film, and fentanyl, patch. Several of these agents are formulated with abuse-deterrent technologies. Because he is getting good pain relief with oxycodone co-formulated with acetaminophen, converting to an extended-release formulation of oxycodone seems the most logical choice. JPK is currently taking 8 5 mg tablets of oxycodone daily, that is 40 mg total per day. This may be directly converted to extended-release oxycodone 20 mg orally twice daily, with elimination of the short-acting product. If he continues to have nausea after his doses of oxycodone, he may need to rotate to another opioid or use a non-oral route of administration, an antiemetic, or a non-opioid analgesic. JPK has been using several different analgesics for his pain, including a non-steroidal anti-inflammatory drug, an anticonvulsant, an antidepressant, and an opioid. These agents will offer pharmacologic activity at several points in the pain pathway and offer additive analgesic effects. However, multimodal therapy also carries the risk of additive adverse effects and possible drug interactions. For example, the anticonvulsant and the opioid may cause additive sedation. The balance between adverse effects and analgesia must be considered with any changes in drug therapy. He is also taking lisinopril, using a non-steroidal anti-inflammatory drug concurrently with an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker may cause hyperkalemia or acute renal blood compromise. A non-acetylated salicylate such as salsalate or diflunisal may offer analgesia with a lower risk potential and fewer adverse effects and drug interactions. They have minimal effects on prostaglandin production. JPK returns 6 months later, after seeing a pain specialist and a psychologist. He is now taking gabapentin 1,200 mg by mouth 3 times a day, meloxicam 7.5 mg by mouth once daily, amitriptyline 25 mg by mouth every night at bedtime, and oxycodone controlled release 20 mg by mouth twice a day. So my question to you reads: how should JPK's therapy be monitored? Clinicians must assess each part of JPK's care plan, both the positive aspects and the negative aspects. Is JPK meeting his goals on his personal care plan? Is he getting more sleep? Is he more physically active? Is he managing his stressor better? Is his pain improved? There are several monitoring tools that may be used routinely to record long-term progress. The 5 A's of monitoring therapy are often used, namely analgesia, activities of daily living, adverse effects, effect, and potential aberrant drug-related behavior. In addition to monitoring for efficacy, assessing for adverse effects of his medication is critical. Gabapentin may cause sedation, dizziness, edema, and cognitive impairment of short-term memory, concentration, and word finding. Meloxicam, a non-steroidal anti-inflammatory drug, may cause gastrointestinal upset or ulceration, so he should be advised to watch for black, tarry, sticky stools or any sign of internal bleeding. He may experience easy bruising and bleeding related to the platelet inhibitory effects of non-steroidal anti-inflammatory drugs and should have his serum creatinine and potassium checked regularly to monitor for non-steroidal anti-inflammatory drug-induced renal toxicity. His blood pressure should also be monitored regularly because this has been elevated in the past. Oxycodone may cause constipation, sedation, dry mouth, and urinary retention. If he is using the opioid regularly, he should be advised to also use a bowel regimen with a stool softener, osmotic laxative, or a motility agent. Additionally, if he is using the opioid for an extended period of time, he may need to have his testosterone levels checked and bone density testing done periodically to monitor for hypogonadism and osteoporosis, which are associated with chronic opioid therapy. Amitriptyline may cause additive sedation, constipation, and urinary retention. He is unlikely to have problems with orthostatic hypotension, but this is common in older patients. My next question to you reads: what non-pharmacologic therapies may be beneficial for JPK's pain? Coys and colleagues found that most guidelines recommend a supervised exercise program, cognitive behavioral therapy, and short-term pharmacologic therapy. The APS recommends that epidural steroid injections and possibly surgery may be considered in patients with persistent radicular low back pain. Because JPK has radicular pain into his legs and he has tried first-line therapies, he may be a candidate for an epidural steroid injection. This will only offer temporary relief, at best, but may provide him enough relief to participate more in physical rehabilitation. Studies show mixed results with both injections and surgery, so JPK must be part of the decision-making process. In the past, patients were advised to use bed rest for acute back pain. It is now recommended that patients remain physically active. This has been shown to improve pain and function at 3 to 4 weeks compared with bed rest. Bed rest is also not recommended for chronic back pain. JPK still has limited physical activity and was noted to be deconditioned. Inactivity can increase muscular pain. A referral for physical rehabilitation is a key component of management, specifically a supervised exercise regimen. There is no difference in benefit among different forms of exercise, so JPK and his therapist may build a program that best fits his interests and needs. Physical rehabilitation also may include stretching and strengthening, but these are not effective unless used as part of a comprehensive exercise program. Other modalities such as cold packs to reduce inflammation in the acute phase of an injury and heat to relax muscles may be used, but there is no evidence supporting either of these therapies. Spine manipulation and low back corsets have shown some efficacy, but other physical modalities such as massage, ultrasound, traction, injections, acupuncture, or shoe lifts have not been shown to be effective. JPK may report that he has more pain after he starts an exercise regimen, because his muscles get reconditioned. JPK should be encouraged and given assurances that physical activity that is at an appropriate level for his needs may cause him to hurt but will not harm him. He can also learn how to pace his activities so he does not overdo it with yard work as he has done in the past. Cognitive behavioral therapy, abbreviated as CBT, and mindfulness-based stress reduction, abbreviated as MBSR, have been shown to improve back pain and functional limitations. Mental health care is an essential component of multidisciplinary pain management. Cognitive behavioral therapy works on a patient's perception of pain and expectations, focusing on mood, catastrophizing, negative thinking, and poor coping skills. Mindfulness-based stress reduction focuses on increasing awareness and acceptance of moment-to-moment experiences including physical discomfort and difficult emotions. After JPK's depression is addressed, he can work with a therapist on coping skills and how to use self-regulation and manage stressor. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 381.